Well, thank you, Peter. And obviously, as David's not here, there's just a couple of things I wanted to add. He did ask me to record his own thanks to Hilda for her contribution to the Trust, and the level of service that we're able to offer has been hugely informed by the feedback that we've had from service users through Hilda. And I think she will be very much missed, both as a friendly voice to the Trust and a critic of what we do. And I'm sure that her colleagues will miss her enormously. Just picking up on some of the things that Peter commented on, I think it's really important to recognise what's been achieved during the year, despite the pandemic, with extraordinary performance by people driving forward the agendas within the various departments and teams. And I think we have to recognise that. And Nikki is a great sort of in representation, if you like, of the COVID response, which I know has been an impact on absolutely everybody. And I think it's important for us to recognise as non-execs the extraordinary privilege we have to be on a board where the executive team has worked the way it's worked, and know that all of the activity of the Trust is in incredibly good hands. The other thing that's worth noting is just how exciting the future is. We're right on the brink of a whole new world of delivery across the system and within the Trust and then within mental health care. Despite the pandemic, we've got an awful lot to look forward to. The care and engagement we've given to our people is not to be underestimated, and I think we see the benefit of that reciprocated in the response on the staff survey. So people want to tell us because they trust us, and that's an incredibly good sign. So just really to recognise the thanks that we owe to Peter and his team for the work that's gone on in response to the pandemic. As I said to Nikki, we're not there yet. This has still got to go on. So. Not a sprint, but a very long marathon, and I know that people will continue to perform well and take their teams with them. So thank you for that. We have a really good number of questions from the public, and what Joe is going to do is going to put them on the screen, and then I'm going to hand over to my learned exec colleagues to give response to the public. So Joe, if we can have those questions up, please. So this is one about an example of a good care plan, and I'm going to go across to Bookie to respond to this, please.
Actually, Chair, I think take this one.
So is it you, Kenny? Apologies.
Yes, no, that's absolutely fine.
Sorry, Bookie, is your heart still going?
Not at all.
Yeah, so thanks for the question from Michelle. So in essence, really, that a care plan is at its most basic level. It's an agreement between someone who uses the service and the cleanicians who they're working with. So really, defining quality is quite an individual thing, but really basically, the things that should be in a care plan are about defining what an individual wants to get from engaging with our services, so treatment goals and interventions, who is responsible for overseeing them, because that could be someone who is working in our service, it could be a family member, it could be the service user themselves, or another party that doesn't work in the Trust, and they're all really important concepts. And also it should be written in a style that everyone understands. So they're the kind of basic fundamentals, but what it looks like for everyone, each individual will vary, because everyone's at different places in terms of their recovery journey. But in terms of the exact ask, we can absolutely share an example of a care plan. We can anonymise a care plan, and we can take that through our service user and care council, actually, and that might be a really helpful thing to do. And the other question, part of the question, was about what do people do when they feel their care plan doesn't reflect what's seen as good quality. Then the first port of call, of course, is their clinical team is raising that concern with their care coordinator. So that's the route for raising an issue. And then if they don't feel that has been resolved or is resolvable through their clinical team, then of course we've got our PALS team internally, where they can go for support and advice about how to resolve that issue if they feel it's not being tackled within the service they're accessing. So I think that's the basic question. We can follow up on Michelle's question at the Service User and Care Council by doing some work. hopefully that's a helpful answer for Michelle.
Can I just add to what my colleague has said, and it's that bit about working with the Service User Care Council. We, as in the doctors, did this about 2 years ago to agree what's called a standard care plan, and just exactly how Kenny's described it. And I'm sure we'd be happy to go back to the Service User Care Council if there's a need for this to be revised. Thank you.
Thank you very much, both of you, and I hope, Michelle, that answers your question. So we have a number of questions from Jamie Ward on behalf of Healthwatch. The first one is around the vexed question we've just been discussing about the delivery of vaccinations, the confusion about that. That Kenny, Bucky or John to respond, please.
I don't mind taking this initially, Janet, if you'd like. So in terms of the first question, in terms of residents and the inconsistency of delivery of vaccinations, I think nationally it's important to note that the government issued a directive from the chief medical officers on the 30th of December, and that was to tell all NHS providers that we must stop giving second doses at 21 days and move to a regimen of 12 weeks. And that was to maximise the number of people who have received the first dose of the vaccination. I think this has caused some residents some confusion because some have had both doses at 21 days. And the reason for that is because we had a number of elderly patients, particularly those over the age of 80, who were booked in for their second dose before the date of the 10th of January. And after discussions between Bucky, Kenny and myself, we did make a decision as a trust that for our GP practices, those who were booked in at such short notice, those elderly patients, continued to have their second dose. However, I can assure the board that in line with what we've been asked to do, we have now stopped giving 21-day second doses and we have moved to 12 weeks.
Thank you very much. That's helpful. Kenny, the second question looks like an offer from Healthwatch to work with them on a virtual form of enter and view. Would you like to respond to that, please?
Yes, absolutely. So we've talked many times at board about how helpful working with our partners at Healthwatch is in terms of these visits. It's obviously been hindered by COVID and the need to reduce footfall into our premises, but absolutely, we've done, as a consequence of COVID in 2020, we've really done wonders in terms of moving to digital working. So we'll absolutely take up the offer from Healthwatch of trying to roll out a solution that's based on a digital enter and view. So absolutely no problem working with them on that.
Thank you very much. That's good. Long-term COVID, are there any support groups that we're aware of? Is that one for you, John?
Sorry, just struggling with my mute button. Yeah, myself or Kenny probably. So at the moment, we're at the stage and we're actively engaged in establishing the clinical pathway that we've been asked to do as a system nationally for patients, people who are suffering from long COVID, and that covers the physical and mental health implications of having COVID that may be present in those that haven't simply had an illness that perhaps is mild and lasts a couple of weeks. I have checked, we're not aware of any virtual support groups for patients in particular, but this is something we could indeed set up with the people who are running the pathway, and again in collaboration with our Service User and Carer Council, I think. So what I'll do, there are particular people in the trust working on this pathway with system partners, and I will ask them to consider this as an area that they could pursue.
Thank you very much. The next question relates to one of the earlier ones, really about priority for COVID vaccination for people with multiple existing conditions. Are we able to comment on that at all?
Yeah, so as a mental health trust, Janet, I think we're probably not best positioned to advise on specifically priority groups in terms of physical health conditions that may mean people are the priority group for COVID. But what I would say is any patient who believes that they should be in the priority list due to conditions such as those that the member of the public has mentioned should discuss that with their GP practice, and that would be the first point of call to address that. The national target timeframe for vaccinating the most clinically vulnerable and at-risk groups in terms of age groups is the 15th of February this year. So vaccinations, as people will have seen, rates are increasing daily. So people who fall into those priority group categories may not have been called yet, but they should expect to be called before the 15th of February. But as I say, any concern from individuals, then they should speak to their GP.
Thank you very much. Before we move on to this question, Joan, do you have a comment?
Yes, thank you, Chair. It was just really, for the sake of completeness, a follow-up to Jonathan's reply to that last question. And in terms of Jamie's question about if a GP is then referred, whether or not the GP has that discretion to be able to add to the list of conditions which the government has actually prescribed.
Kenny,
Kenny might be best to answer that.
Yes.
Yeah, so I can answer certainly at a high level. I'm sure Keith may have a view as well. So the vaccination program, as everyone appreciates, is a highly prescribed process based on what the Joint Committee for Vaccination and Immunisations at national level has deemed to be the highest risk groups. So as we go through the vaccination program, we start with, as everyone's aware, people that are over 80, people that are resident in care homes, health and social care workers, and we go down the list according to the highest risk groups. Now, at some point, we will get to, I think it's, again, I might apologies if I'm slightly wrong, I think it's cohort 5, which is the people with who are adult age with comorbidity, so long-term conditions, which would include this reference case here. Now, that won't be far away because the vaccination pace is picking up and the amount of people getting access to the vaccination is increasing. But in terms of an individual GP practice, I know that they are and all of the healthcare system is being asked to follow the JCVI recommendations in terms of who we target first. But I think it won't be long before this group, I'm talking about perhaps the next couple of weeks, will have access to the vaccine. I'm sure Keith might have a view as well as being a working GP.
Thank you, Kenny.
Yeah, would you like me to come in there?
Yes, please. Thank you, Keith.
Yeah, the recommendations are quite prescriptive, and if you deviate from them, you have to be prepared to explain why you've done that. However, common sense must prevail, and whilst the emphasis has been on the age categories, there are clearly some people who have extremely complex comorbidities. And we've just taken a common sense approach within our PCN and decided, yes, we'll vaccinate these. So, for example, now we think we've vaccinated most of the mobile people over 70, and we've already started vaccinating people with comorbidities, some of which are not on any recognised list, but it's just barn door obvious that's what they need. So we've gone ahead and done it.
Thank you, Keith. That's good news, and I think reassuring for people in this situation. Jenny, you've got your hand up. Is it a relative point?
Sorry, Chair.
That's okay. Fine. Thank you, Joe. Thanks to Jamie for putting those questions through from Healthwatch. This next one from Kelly is about how we plan to support our mental health services as our demand for support rises and funding reduces. So, Bookie, can I ask you to comment on that?
Yes, I'll start, and I'm sure John will add to it. I think what we have seen is that we nationally, lots of money being given to mental health trusts, and we certainly have our Access and Crisis Care Centre, which is something that people can access 24/7, and you don't need a referral from your GP. We are keen that anyone who suffers mental health crisis doesn't have any barriers in place before they can get help. And I think there's a reference to an increase in suicide rates, which I have to say, don't recognise in terms of that happening locally. I think what we do know is that the suicide rates increased previously, but we have been able to get this down, particularly working with our partners. One thing we do have to recognise is that it isn't mental health trusts alone, but it's all it's working with people in general, because people may not know that only 1/4 of people who die by suicide actually come in contact with mental health services. So it's about everyone recognising when people are in crisis and getting them the help that they need. There are a lot of developments, which I think is good news for people with mental health services and in our trusts, and I'm sure John will say a bit more about this. Again, working with partners, we have been developing specific services for people. So, for example, personality disorder services and pathway we are developing to ensure, again, that people have access to the right care when they need it. Also in terms of eating disorder services, as well as a lot of development with CAMS services. So I am, really keen that people are aware that whenever they need help, our services are geared up to at least for people to access mental health services when they need it. I don't know whether John wants to say a bit more about that.
Yeah, if I can, I would just ask, thank you, Bookie. At the moment, we've had a lot of, in terms of the resources and as expanding our community services, I think it's fair to say over the 5-year forward view and the long-term plan, the first years of these were very much focused on crisis and other aspects of mental health provision. So we have expanded over the past sort of CAMS services, obviously mental health liaison, we have the crisis centre, we have various other services that we've invested in. I think it's good that the long-term plan for the next 3 years is really changing its orientation. So from April, significant additional resources and funding is being made available to community services specifically. And that will be across our STP over a 3-year programme of work. We're about to submit our bid for improvement and our plan for improvement on the 20th of January. That's been pulled together across the whole STP between our colleagues in Combined, the local authority, and Midlands Partnership Trust. And that sets out quite an ambitious plan for expanding our community services and increasing the resources that are available there. So I think that's really positive, and I would ask Kelly to watch out for those developments in community services, because they will allow us significant expansion and development of those services over the next couple of years.
Thank you both very much. Joan, do you have a comment?
Sorry, did you say Joan?
Yes.
Sorry, Chair. Yes, I did really. I don't know Kelly Robinson, who asked this question. I've just been looking to see whether or not they're actually in the chat, actually attending our public meeting with us. But what I really wanted to kind of crystallise is that we're doing the very best that we can for our crisis emergency services. We're looking in the investment under the mental health investment standard to see how we can extend that in terms of, as Jonathan said, outreach into the community sector. But I think that if there's a kind of perception in the local community that more needs to be done, however much has already been done, then I'm just really asking what processes we have for actually, and I don't know whether or not we've done this already, but sitting down with Kelly and others who might have this question to start to look at the perceptions that there are, and within the wider system to look at ways in which it's not just ourselves that provide the services. You know, there's a huge amount of support from the voluntary sector, from the local authorities in terms of social care and the whole prevention agenda. And my worry is, for example, that in the council, Stoke-on-Trent City Council's new budget proposals, there are going to be further substantial reductions in spending on some of that social care aspect. So I suppose really I'm just asking how, in dealing and answering this question, we somehow or another transfer the points that are being raised into the wider partnership systems approaches towards preventing mental ill health and making sure that when it's needed we have the partnership to be able to address all needs, and the role, I suppose, of service users in that as well. And it's just how I'm not suggesting that we deal with it now, but it's our ongoing work, how we factor that in to looking at all aspects of this.
Thank you, Jen. Peter, do you want to just briefly respond on that?
Yeah, I'm conscious of time, but thank you, Chair. So, I am conscious that there are a variety of agendas across the system, mental health being one of them, that need to be further joined up, whether that be third sector, local authority, NHS, or other wider determinants of health items such as housing, etc. The ICP is a vehicle for that. We've discussed it on a number of occasions. We're not there yet. I would ask for people's patience in terms of the development of that programme. I would like to use mental health as one of the main focal points for the Northern ICP to create a proof of concept in relation to that joining up of the agenda. In terms of the specific investments mentioned, internally we're going through the kind of norming and storming phase of that programme, so we're not there yet in terms of wider communication, but that will flow naturally through the development process that John describes. That is internally. So Kelly, for example, the healthcare support worker that's mentioned there, will understand what progress is being made through that communication process internally. Externally, as I mentioned a moment ago, the ICP process will be some help, but we also need to think about the channels to get the wider population up to speed and involved, and things like our service user and carer council processes will clearly help that, as well as publicising this conversation on our website, of course.
Thank you very much, Peter. And I think we have one final question, Joe, which is from Louise Williams, who's a parent, who's asking about special educational needs children and what we're doing to support them. Is that one for John?
Yes, Janet, I think it is, or I'll certainly try to, and anybody else from a clinical point of view can then come in. So we're trying to expand our services at the moment for children overall. There's a very clear ambition in the long-term plan, and we're committed to that in terms of our children's services. In terms of children with special educational needs in particular, we do have a couple of schemes that are rolling out and will be expanded to improve the support for children with special educational needs. So first of all, we have been the early implementer, as people know, of ACAMS in schools, then the mental health support teams in schools, which puts mental health workers and support workers directly into educational establishments, whether that be schools or colleges. We currently cover 40 plus across Stoke-on-Trent and North Staffordshire, and we are eagerly awaiting the next tranche of funding because we've got a really good template now to allow us to expand that over into other schools as more funding becomes available over the next couple of years. So we're eagerly awaiting that development to allow us to expand that further. We've also done some work this year. We've submitted a business case just recently to our commissioners for agreement for improvement to our ASD services for children and young people. And that case basically allows us to level up our ASD services with those that are now available in the south of the county that have been improved very much so in the last 18 months since they moved to Midlands Partnership Trust. So that business case has been written, it's been approved and is in with the CCG, and we're waiting to hear of the success of that and the funding that might be made available for that. But that would essentially allow us to more than double the capacity and the skills and workforce within our ASD services for CYP. So we are chasing that at the moment. And I think finally, I'd just point out that the Trust was given access to a tranche of winter funding and non-recurrent funding from November through to March to expand mental health services, partly over winter and partly in response to the COVID impact on adults, children and young people and older people. So we were given some freedom to spend it as we wanted to. And what we did with £100,000 of that funding with our CCGs is we have commissioned additional children's wellbeing support from the voluntary sector that we already work with for this specific period, and Changes and North Staffordshire Mind are providing that extra capacity for us, and that's been in place since November and will continue through to the end of March.
Thank you, John, for that very comprehensive response. Does anybody want to add anything to that? Or no, that's great. So thank you to members of the public for submitting their questions, and we hope that we've addressed the issues that you've raised.